ask Muhammad al-Mawardi one question. I was worried about celiac disease, refractory celiac disease. I'm worried now about normal intraepithelial lymphocyte, refractory celiac disease, wheat sensitivity celiac disease, allergic malabsorption. So how to deal with these cases? All these patients should be gluten-free diet?
Yeah, that's the problem with technology. As we advance, we get complicated. There's a big quite difference between celiac and its complication with the gluten and wheat insensitivity. As I said, there's a difference in the future and prognosis. So in wheat allergy and in non-celiac gluten sensitivity, there's no the prognosis is much better. It's basically, there's symptoms, but there's no possible complications like lymphoma or jejunal ileitis like celiac disease. Of course, the entity has been discovered because we've been seeing patients complaining of symptoms in the presence of in exposure to gluten diet, but with a normal serology and normal biopsy. Now, don't forget, we have to give an attention to potential celiac disease, so people who have a positive serology but with normal endoscopy, and silent celiac, which is totally different. So we have to give an attention. Their prognosis is much better than celiac disease itself.
Right, Muhammad Al-Bagher Ahmed, Division of Gastroenterology, King Khalid University and Asir Central Hospital in Abha. Many thanks to all the speakers. Just a quick comment and a question for Dr. Alan Barkin. Is this interaction between clopidogrel and antiplatelets and PPI, is this similar for all types of PPI, or is it confined to, say, omeprazole and esomeprazole alone? And would you advise spacing if you need to give patient who needs a PPI and needs a clopidogrel? Would you recommend spacing the doses, taking PPI in the morning and clopidogrel in the evening?
Right. Thank you for the question. I'll answer the second one first. I guess you have to decide whether you think there's an interaction or not. As I told you, I think most of us believe in fields, both in cardiology and gastroenterology, that there is no significant clinical interaction. That would obviate both your questions. Nonetheless, if you're still concerned despite that, the problem is that the FDA has made a number of recommendations and they're not evidence-based. The issue of going ahead and separating the dose by 12 hours to try and space them out to minimize the interaction, in fact, is not supported by observational pharmacokinetic data. It remains theoretical. And there was some data that was provided to the FDA that presumably suggested this was the case. These data were not made entirely public, and when reviewed by some of my colleagues, said that there were no data to support that. So you can certainly do that, but be aware that it's not really an evidence-based recommendation. Stepping back one, that's an easier one to answer, is in fact, as I mentioned to you, the original recommendation to avoid omeprazole was based on two bodies of data. The first one was pharmacodynamic data of interaction, and then the second, the main one, was actually the Canadian observational clinical study. The issue of the pharmacokinetic data are all over the place and really do not stand the test of clinical relevance, and the Canadian data were faulty. And I can show you the majority of the high-quality papers suggest that there is no difference between omeprazole and other PPIs, number one. Number two, the only randomized trial data evidence we have is actually on omeprazole. It's DAPT plus omeprazole versus placebo, and didn't show any signal in 3,800 patients, despite the study being concluded prematurely. So for both those reasons, I think it's very unlikely that there's a significant interaction that is more so involving omeprazole than others. However, I understand that the FDA made the recommendation it does, and what I would recommend to you is two things. If the Saudi FDA equivalent does not have any formal recommendation suggesting that you need to stick to pantoprazole, let's say, or in my country, dexlansoprazole, then by all means use any PPI. I would feel very comfortable, certainly, prescribing either. If you do work in an area where, in fact, the regulatory agency has suggested that you need to use, if you're going to use a PPI, either pantoprazole or I'm told rabeprazole in certain places that would be the case, then by all means go ahead. I don't want you to put yourself in a legally difficult position, but be aware that if a patient is already on a PPI, switching that patient over to another PPI causes a non-adherence rate of about 15%, and if that patient needs the PPI for, let's say, for prophylaxis of bleeding, you're playing really with fire in that context. So in that particular issue, I would not recommend switching the patient over just based on those weak, poorly based recommendations.
Hani Jawa from King Abdulaziz University Hospital. So my question is also to Dr. Barker. Earlier in your presentation, you mentioned the issue of us over-prescribing PPIs. So my question is, can you give us some tips on, or what do you think are the most common or frequent reasons of inappropriately prescribing PPIs? So that's my first question. And then my other question, if you could please elaborate more on the use of PPI in the setting of decompensated cirrhosis. Thank you.
Thank you for your questions. So the first one is, what is the biggest source of inappropriate use? Well, I think it's a little bit different. In the context of the hospital setting, it's really patients who aren't that much at risk for stress ulcer bleeding prophylaxis. I would say that's the one. We actually just finished a meta-analysis, you may have seen published in Red Journal, suggesting PPIs are actually more effective based on randomized trials. And we actually just finished a cost-effectiveness analysis that has just been accepted for publication in an economic journal, suggesting that actually is an economically dominant strategy over H2RAs. So I think I accept using stress ulcer bleeding prophylaxis as an indication, but still, unfortunately, it's only a very small proportion of patients who actually fit those criteria, and you see a lot more than that in the hospital setting. In the community setting, I think the two most common in my mind would be the use of double-dose PPI right off the bat for a number of patients who really don't need it. And I'm not saying it comes from gastroenterologists or specialists, perhaps as much from GPs or primary care physicians who will start with double dose when in fact they should be starting with single dose. I think that's a common one. And the other, and pardon me to be a little bit crude, but anybody who is passing gas from above or below and has any type of discomfort between the mouth and the belly button gets a PPI these days. And those, as far as I know, and having looked at the recommendations, those are not the best indications. So I think we need to stick to published indications in this context. And in fact, if you counsel the patients appropriately and already tell them that they should use as little as possible, as infrequently as possible, but enough to be comfortable with regards to symptoms, you actually find, and we know this from observational studies, that most patients end up taking PPIs about once every third day or so. So there'll be contact. Your second question is a more problematic one because we don't have a huge number of data, a huge amount of data on that. I know of 2 studies that have looked at PPIs in the context of severe or liver disease, active liver disease, hospitalized patients. The first one was a terrible study, very poorly done, and that actually linked the increased incidence of spontaneous bacterial peritonitis in the context of cirrhosis. It's hard to do any study, and I respect anyone who publishes because research is difficult to do, but methodologically it was a weak study. The second one, the one I talked about here, is actually a much stronger study. It actually looked at propensity analysis, which is a method of pseudo-randomization to try and kind of best equilibrate patients, balance patients in between the 2 groups. And compared to H2RAs, they found that PPIs had an increased risk of serious infections during the hospital stay of decompensated cirrhosis. One of the issues is, as you know, we do use PPIs post-banding in the context of bleeding. And so there's an issue there. And I don't think we have a huge amount of data. So I think you need to use your judgment. Again, I think in the context of, if it's a clear indication, such as post-banding, there's actually one randomized trial, as you probably know, suggesting that it decreases the rate of rebleeding from ulcers post-banding. Then I think it's reasonable. Otherwise, again, if it's not indicated, by all means take it out, and perhaps with an even lower threshold from doing that in the context of a patient admitted with decompensated cirrhosis. That's as much as I can say.
Thank you very much.
Thank you very much. I think we have to conclude at this stage, and now we give the